A little bit about the hospital. We are a 45-bed JCO accredited hospital. We're fairly small considering all the other hospitals that are out there. However, we are, according to IHS, one of the largest hospitals. And we do bulk of our hospital care out in outpatient services. So our patient population is about 17,000, and as of August of 2008, we had fully implemented electronic health record and CPOE. To set the tone for this whole DVT prophylaxis, one of our pharmacy practice residents decided to do a pharmacy-driven electronic health record medication reconciliation. So the pharmacist would go in for every patient that was admitted and do an interview on their medication history as well as how they were taking it, when they were taking it, and any over-the-counter medication or whether they were getting health care from outside the facility. So according to our PMP, they were supposed to be completed, the medication reconciliation was to be completed within 24 hours of admission. And then the note was then forwarded to our attending for further review as well as a sign-off on that. The implementation team initially consisted of a pharmacist and 2 internal medicine physicians. And we had gotten various protocol from a lot of the institutions, and we kind of tailored it to our hospital and to our patient population. And then the draft of the protocol was presented to the providers and to the rest of the pharmacy staff for feedback. Then in October 2009, we had incorporated the DVT Prophylaxis Recommendation into the medication reconciliation. So for every patient that was admitted, it was then forwarded on to our attending for sign-off and for review. So we looked at, for patients who had 2 or more risk factors and or 1 high risk factors, we recommended DVT prophylaxis. Our preferred agent was heparin, so heparin sub-QQ8, or if they had undergone an ortho procedure such as a knee or hip replacement, we did recommend enoxaparin. And also we recommended CBCs to be drawn every 5 days. And pharmacists would follow every one of these patients in their labs just to ensure that the platelets didn't go down and that they did not experience HIT. So we did an outcomes pre and post implementation, and we looked at it over a 90-day period, and we looked at 45 patients over that time period. And during that time, we had realized that pharmacists rarely made any form of recommendation. It wasn't because they didn't want to do it, it was just because it wasn't part of their routine. It wasn't laid out simply for them to recommend, so they were busy doing other things, so they weren't really focused in on that. And during that time period, we had only seen 36% of the patients prescribed DVT prophylaxis. Now, mind you, most of our patients are obese, they're diabetic, and they come in with infectious disease process. So a lot of them are qualified for DVT prophylaxis. And we did have a 4% incidence of DVT occurrence. And after the implementation, pharmacists now, that was part of their daily routine. They were recommending DVT prophylaxis, and we had an increase of 51% of patients prescribed DVT prophylaxis. So we still have room, and we looked at the months of this January through March, and we increased dramatically to 81%. So quite a jump. We had no reported incidence of DVT during this time period, but we also did see a potential hit. So we were monitoring her platelets, and it plummeted down from 289 down to 85. So we readily discontinued that. We didn't have any other options, so she did fine after the discontinuation, and her platelets went back up. So of course you're going to have barriers when you're implementing any new project, and some of the risk factors weren't interpreted the same by the providers to providers as well as pharmacists to pharmacists. So like paraplegic patients, they thought they're wheelchair bound in outpatient, they're going to be bed bound in inpatient, why put them on heparin? Another thing was, okay, the patient has multiple risk factors. Yes, they're obese. Yes, they have infectious disease process. Yes, they're diabetic, but guess what? They're mobile. So they would go ahead and discontinue that. So we have a little bit of education needed. Knowledge of the pharmacists and providers regarding the dosing of heparin. Prior to the implementation, we had seen no heparin being dosed as sub-Q Q8. A lot of them were dosed Q12. So we did see an increase of the Q8 after the post or after the implementation. Patients were also a barrier. They didn't want to be given sub-Q Q8 heparin. So we also have basal bolus implementation in our inpatient where we try to control their blood sugar a little bit better than what's going on in outpatient. And so they're not only receiving a SPART 3 times a day on top of their basal bolus, they're also receiving 3 times a day of heparin. So that was a minimum of 7 shots per day. So that can be a lot. It's a lot. So in some instances, we would change it to from heparin to enoxaparin. And also dialysis patients, what do we do on dialysis days when they are receiving heparin? Some of them receive heparin, some of them don't, and how much do they get? So that was one of the challenges for us as well. It's always going to be a continuing progress. Always going to be doing a PDSA. We're going to be providing continuing education for the providers. We also do a one-on-one feedback as well. We're going to be collecting more data. How are we doing? Reassess DVT prophylaxis for end-stage liver disease. We're probably going to be having to look at that as well. And dosing of medications for the morbidly obese. Right now, we do heparin Q8. Is that sufficient, or should we go to enoxaparin, another dose to 40 milligrams sub-Q Q12 or 1 mg per kg per day? So that's further thought. And our goal ultimately is to increase it to 90% or even to 100% and to have a never event.